Hello, my name is Kathy Lee, and I'm a T32 research fellow at Mount Sinai Hospital in New York, and I also work at the University of Michigan. Today I'll be discussing emergency department care experiences of older adults, results from a nationally representative survey. I have no conflicts of interest to disclose. So as many of you probably know firsthand, older adults make up a significant and growing proportion of ED visits. Understanding how this group experiences ED care is key to improving care quality for them, as many of them have more complex care needs than the average patient. One way to examine ED care experience is to use patient satisfaction surveys. However, there's conflicting evidence linking the results of traditional patient satisfaction surveys, such as Press Ganey's, to improvements in objective measures of care quality. And these surveys may also have significant response bias. So we developed a survey module for the National Poll on Healthy Aging to examine ED care experiences for a broader, more nationally representative sample of older adults aged 50 to 80. I'll be focusing on the outcomes related to ED care experiences, specifically with regards to care communication and follow-up care, as well as questions about end-of-life care and discussions in the ED. These are some examples of the questions that were asked. In the interest of time, I will not read them out loud. We had over 2,000 responses with a 78% survey completion rate from the recruited panel, with about 1 in 4 reported respondents who reported having an ED visit in the past 2 years. With regards to care communication, the vast majority of respondents felt that they were sufficiently involved in decision-making about testing and the plan for care. And a majority also strongly agreed that the hospital staff took their preferences into account, that their condition was explained in a way they could understand, and that their care plan and discharge plan was explained to them. This table shows the predictor variables that went into our multivariable logistic regression, including age, gender, ethnicity, education, health insurance status, income, and physical and mental health. You can see for this particular question that physical health status was the only significant predictor of whether or not someone strongly agreed with the statement that their condition was explained to them in a way they could understand. To put the odds ratios into more easily interpretable terms, we calculated the average marginal effects for each of these variables, holding other things constant. So you can see that 74% of those who reported being in overall good physical health agreed with this statement, compared to only 55% of those who reported fair or poor physical health. With regards to advanced directives, we can see that the vast majority of people agree that it's important to have a conversation in the ED about their advanced directives, and that over half of them expressed some concern that the care that they thought they would receive in the ED would not be consistent with their wishes. And in multivariable analysis, Medicaid insurance, as well as identifying as Black or Hispanic, were significant predictors of concern for this. Lastly, with regards to care coordination, the vast majority of people were able to fill prescriptions and follow up with their primary care doctor, but only 2/3 were able to follow up with a specialist as directed, with employer-based insurance and higher income being positive predictors for this. And also notably, less than 1 in 4 people who said they were supposed to receive home care services after discharge were able to do so. This held true across all predictor variables, but the numbers for this were small, so we may have been underpowered to detect the difference. Our study had a number of other limitations listed here. In conclusion, in a nationally representative survey, older adults were largely satisfied with communication and information sharing in ED visits that they had experienced. and a majority agreed with the importance of discussing advanced directives and end-of-life care during an ED encounter. And lastly, some areas for improvement that we identified were a need to focus on better communication with potentially vulnerable populations, in particular those who were sicker or had poor physical health, as well as minorities, and those with Medicaid insurance, and a need for better care coordination, especially in coordinating specialty follow-up and home care services. All right, thank you very much. I will be available for questions.
Hello, thank you for the opportunity to present our abstract. My name is Manuel Celadon, and I'm an Assistant Chief of Emergency Medicine for the VA Greater Los Angeles Healthcare System. I have no financial disclosures. The US declared coronavirus disease 2019, or COVID-19, a national emergency on March 13, 2020. Early in the pandemic, the CDC's MMWR reported that total US ED visits dropped by 42% when compared to previous years. In another report, it was noted that in the 10 weeks after the emergency declaration, this decline included decreased visits for life-threatening conditions such as acute coronary syndrome, or ACS, which dropped by 23%, and acute stroke, or CVA, which dropped by 20%. Anecdotally, we saw similar declines in ED volumes at the Greater Los Angeles VA. Every shift we asked ourselves, where did all the patients go? What happened to all the heart attacks and strokes? Is this only happening at the VA? The Veterans Health Administration, or VHA, is the largest integrated healthcare system in the US. It provides care to over 9 million veterans. Therefore, we thought it was a good idea to study this in this population. We aim to assess the COVID-19 pandemic effect on overall VHA, ED, and urgent care center visits, and those for life-threatening conditions such as ACS and CVA. Our study population included patients presenting to one of about 140 VHA, ED, and urgent care centers across the US. VAEDs serve a large catchment area and are set up in a hub and spoke model. In 2019, these VHA sites saw about 2.2 million patients. The study centered around the 261-day period starting about 2 weeks before the national emergency declaration and going through November 15, 2020, when the US was in the middle of its third wave or surge of COVID cases. We obtained national ED and urgent care center data from the VHA Support Services Center, which collates encounter data in VHA's corporate data warehouse. We identified ICD-10 codes that were most likely to represent acute coronary syndrome and acute stroke. We tabulated the total number of ED and urgent care center visits and those for ACS and CVA during the pandemic from March 1st to November 15th, 2020. And to account for season-based confounders and as well as year-to-year variation in the total number of ED and urgent care center visits, we compared visits to past visit averages for ACS and CVA from March 1st to November 15th in the years 2017 to 2019 and computed that using the same search methodology. During the 261-day span studied, there was a 24% decrease in total VHA, ED, or urgent care center visits from a mean of about 1.8 million annual visits in 2017 to 2019 to about 1.3 million visits in 2020. In 2020, the number of observed ACS and CVA visits decreased by 8% and 11% respectively when compared to the previous 3-year average. This slide shows the 20% change in total ACS and CVA visits for the US healthcare system overall and for VHA. We obtained this data from the CDC MMW report. In this report, they noted that in the non-VHA US healthcare system, total visits declined by 42% in 2020. In VHA, they also saw a decline in number of total visits. In the VHA, we also saw a decline in number of total visits, but the decline was nearly half that size at 24%. Similarly, for ACS, there was a national decline of 23%, whereas in the VA, that decline was nearly a third of the magnitude of that at 8%. And for CVA, the national decline was 20%, while at VHA it was just 11%. The study had a few limitations. Since we were tracking ICD-10 codes, it's possible that ED providers entered inaccurate or incomplete ICD-10 codes for patients. However, the methodology that we used mimic that of other published studies. This data also doesn't capture the extent to which veterans presented to non-VA emergency departments for ACS or CVA or other visits, just because it was closer to their home. This is an area for potential future analysis. There could also have been seasonal and year-to-year variation in patient volumes. We attempted to mitigate these confounders by utilizing the averages for the previous 3 years at VHA, so the 2017 to 2019. In conclusion, the Veterans Health Administration observed significantly less decline in ED utilization compared to the overall US healthcare system. And given the increased morbidity and mortality with delayed diagnoses of life-threatening conditions, further assessment is needed to identify which factors facilitated veterans seeking timely care during an ongoing pandemic. We believe that the Veterans Health Administration's longstanding commitment to access to care, given that most of our veterans have access to PCPs, and it's also the VHA is the largest integrated healthcare system. The fact that the VHA has long had, I think since 1996, had a commitment to clinical call centers and expanded their utility and resources throughout the years, as well as the low cost of healthcare for veterans, and the rapid expansion of virtual care during the pandemic. We believe that all these were contributing factors to our findings. However, we need a further assessment to identify which exactly led to the significantly less decline in ED utilization that we saw at the VHA when compared to the overall US healthcare system. Thank you for the opportunity to present today, and please feel free to email me any comments or questions at my VA email that is listed. Thank you again.
Hello, thank you for viewing this presentation today. My name is Edward Castillo. I am a professor in the Department of Emergency Medicine at the University of California, San Diego. Today, I'm going to be talking about ED utilization before and after the Affordable Care Act. Before I start, I would like to thank my co-authors who I would not have been able to complete this research or this presentation without their assistance. I have nothing to disclose. So the Affordable Care Act sought to increase healthcare coverage by making health insurance more affordable through insurance exchanges in some states, and that was true in California. Since it was implemented in 2014, however, there have been ongoing efforts to repeal sections or even all of the legislation. So the purpose of this study was to assess emergency department utilization and patient insurance coverage in California before and after the implementation of the ACA. This is a retrospective longitudinal multi-site study of non-federal acute care hospitals in California. We're looking at data from 2009 through 2018. And our data is from the Office of Statewide Health Planning and Development, also known as OSHPD. So the actual data is in two different databases. One is ED discharges, the other one's inpatient discharges. What we actually did is we combined those to get an overall picture of ED utilization. And so for the analysis, we looked at the change in ED utilization, payer type, and overall composite ambulatory care sensitive visits or ACS visits between and across pre and post ACA periods. The pre-period is 2009 through 2013. It was implemented in 2014, so the post-period is 2014 through 2018. And we also report population estimates for these measures. So as you can see, this is this total number of visits. All ED visits increased from 8.5 million to about 11.4 million visits over the study period. You can see actual ED admissions remained relatively flat. So this trend really is based off of the ED discharges. If you're looking, when looking at just the rate per California population, you can see there was an increase pre and an increase post, but a little bit more dramatic increase from 2013 to 2014. And that increase is about 5.2%. So this slide is a little busy, has a lot of information. There's really a couple things that you can see here. One, the private is the blue line, and Medicare is the dark green with the triangles. And you can see these remain relatively flat. So there is a decrease in private over both periods. Nothing dramatic between 13 and 14. Medicare increased both periods, slight decrease between 13 and 14, but the real changes were in self-pay and Medicaid. You can see here, self-pay remained relatively flat, decrease in the post-period a little bit, but you can see there's a dramatic decrease of about 41.6% from 13 to 14. Whereas Medicaid actually increased by about 48.9% from 2013 to 2014. So you can see this is where the shift in insurance coverage actually occurred due to the ACA. We're looking at ambulatory care sensitive visits. You can see they're relatively flat. There is a slight decrease per 1,000 ED visits in Medicare pre, slight increase post, but nothing too dramatic. For Medicaid, it was decreasing a little bit before. That decrease kind of leveled off after. But you can see that there's no dramatic shift from the pre to the post visit. So limitations, OSHPA data does not include federal hospitals such as VA and Naval Medical Centers. That is a kind of a high population in a couple areas like San Diego, but overall, it's the patient population in those centers aren't super large. Billing data or OSHPA data is billing data, administrative data, and it's not research focused. So there is some limitations in that, of course. And this is California data only. So it might not be generalizable to other EDs or other states that participated in the ACA. In this multi-center, so to conclude, in this multi-center tenure study of all non-federal hospital EDs in California to assess the impact of the ACA on ED visits, we saw that ED visits increased over the 10-year period. But in that period, we saw self-pay and indigent or non-insured visits significantly decrease, while Medicaid coverage significantly increased. So that's reflective of that change in insurance coverage over after the implementation. And we also saw ACS ED visits and admission rates decreased prior to the ACA, but remained relatively consistent after the implementation. So it doesn't look like there was any impact on these types of visits after the implementation. So thank you again for viewing this presentation. If you have any questions, feel free to email me at any time. And thank you very much.
Hello, my name is Madhavi Muralidharan, and today I would like to discuss algorithms in identifying emergency department visits amenable to lower acuity care, a semi-structured review and assessment of agreement, which is a project I've been working on with my colleagues Angela Chen and Dr. Ari Friedman. There has been wide interest in unnecessary or avoidable emergency department visits. These visits are considered to be avoidable healthcare expenditures. They constitute unnecessary and invasive testing and diagnostic workup and can further delay access to establishing primary care for chronic longitudinal conditions. In order to study different aspects of these unnecessary visits, researchers must devise methodology to make a distinction between what constitutes necessary and unnecessary visits. They have done this in several ways, including triage codes that nurses give to patients on presentation, and lists of ICD diagnoses that are retrospectively applied to the patient after they have been given a diagnosis. Such lists of diagnoses are numerous and varied in composition. Two of the more popular and well-known examples are Weissman 1992 and Billings 1993. So our research question was which lists of ICD codes have been published and how do they compare to one another? We performed a systematic search to identify and summarize lower acuity algorithms and reviewed the existing validation studies for each. We compared the algorithms to one another using the Jacquard Similarity Index to determine the extent of agreement on the classification of clinical cases. And finally, we validated each list of codes by evaluating its likelihood for predicting diagnostic use, hospital and critical care admission, and death. You can see our search results here. We used an initial systematic keyword search. However, we also used expert consultation, a hand search, and looked through insurance company lists. Overall, we found 14 original algorithms of ICD lists identifying lower acuity conditions. In addition to the 14 original algorithms we identified, we also found 5 studies that sought to validate each of these algorithms. 4 of these 5 sought to validate the paper by Billings et al., while 1 sought to validate the AHRQ algorithm. The findings of these studies were mixed. Many, but not all, found poor performance of the Billings algorithm, and the study that studied the AHRQ algorithm found uneven performance across different levels of analysis and cases. We use the Descartes similarity index to compare the algorithms on a pairwise basis. The average Descartes coefficient was 0.59. However, this ranged from 0.05 on the low end to a high of 0.96. We chose the Descartes coefficient because it does not include the number of diagnoses that were not classified as lower acuity by either algorithm, and therefore is a more stringent measure of similarity compared to the RAND index. We also applied the algorithms to national ED data, which we obtained from the National Hospital Ambulatory Medical Care Survey, or NAHAMSIS dataset. We used triage levels 4 and 5, which represent semi-urgent and non-urgent levels respectively, as points of reference for interpreting the relative acuity of the 14 algorithms. Of all the visits, 25.3% were triaged by the triage system as semi-urgent, while 4.6% were triaged as non-urgent. Our literature-based identification of lower acuity visits based on ICD codes ranged from 0.5% identified as lower acuity to 10% identified as lower acuity. We also studied the predictive ability of these algorithms for identifying healthcare outcomes. The outcomes we studied included admission to hospital of the ED, admission to an operating room, and death of the patient in the ED. Compared with either non-urgent presentations to the ED according to triage, or with ED presentations found to be non-urgent based on ultimate outcome, no algorithm had a negative likelihood ratio of less than 0.78%. In other words, classification of an ED presentation as lower acuity by any of the 14 algorithms was minimally predictive of its urgency according to triage, the resources used during its stay, or the patient's clinical outcome. So in conclusion, the data suggests that no existing algorithm is appropriate for either clinical or payment use. There is a high rate of misclassification for research which may be appropriate for research. However, if applied to insurance use, this could have highly negative effects if patient claims for payment are denied based on inaccurate retrospective applications of ICD-based algorithms. Additionally, we found the predictive power of these algorithms may be limited by their essentially univariate approach to identifying lower acuity ED presentations. Few of these algorithms actually attempted to incorporate interactions between different variables, which may have important outcomes, especially when considering factors such as age, socioeconomic status, regional patterns, multimorbid conditions, or innumerable other variables that all interact to determine the likelihood of urgency or ultimate negative clinical outcome of a particular ED visit. Finally, any attempt to apply these algorithms must consider the original intention for which they were designed, which varies greatly between the different studies. For example, one study's list was originally intended to determine the effectiveness of primary care, while another study compared rates of avoidable hospitalization across different insurance statuses. Therefore, this must be considered if attempting to use the algorithm for another purpose. Thank you so much for listening to our presentation.
Good afternoon. I'm presenting from Rwanda. My name is Ndebwanimana Vincent. I'm the emergency physician and the acting head of department at Kigali University Teaching Hospital. I'm presenting on behalf of my team on the impact of interhospital emergency department transfer intervention on patient outcome and safety. Interhospital transfer system facilitate the provision of necessary care, especially in emergency settings. The lack of interhospital transfer system in the emergency department has been associated with increased mortality and morbidity, and there is a limited study of this kind of intervention between the referring and receiving hospital. Our study design was experimental pre and post study, and has been conducted at Kigali University Teaching Hospital at Rwanda. And we have selected randomly 5 district hospitals transferring to our facilities among 19 hospitals of our catchment area. And all pediatric and adult emergency department transfer patients were enrolled. The intervention which we have done is the emergency department physician calling each hospital, selected hospital on daily basis to consult the potential patient need of transfer, but also to guide on patient transfer monitoring for safety arrival. This is the map showing the selected hospital. You can see that there is one district hospital in Kigali City, and another one in Northern Province, another one in the 2 hospitals in Western Province, and the 1 in Southern Province. The variable which we have analyzed are reason of transfer documentation, transfer time to assess the timely transfer of emergency care, of emergency need, injury severity, disposition, final patient outcome were among the variables analyzed. We have collected the baseline data for 3 months pre-intervention and have conducted 3 months data during intervention phase. The difference outcome based on pre and intervention phase were assessed using statistical analysis. And in total, we have enrolled 110 patients pre-intervention and 93 patients during the intervention phase. Among our patients, the majority were male, up to 65%, and the median age were 37.5. The majority of our patients, up to 67% pre-intervention and 53.7 during the intervention phase, were classified as a trauma patient. As a result, we have found some of the variables with significant statistically, as highlighted. Reason of transfer has been found one of them. And the time to transfer, as highlighted as well, has been improved. And vitals documentation and emergency sign showing has been improved as part of the patient transfer safety monitoring. Another variable which is not statistical significant is a patient outcome. As you might see, where there is a slight reduction in patient mortality from 12.8% to 9.7%. Part of our limitation, some of the period of our research was during the COVID pandemic, which might have impacted our research. And there is a limited knowledge on the patients who were recommended to stay in the district hospital. And again, we don't have a good knowledge on the patient arrival at the original hospital. I mean, the condition of the status when they arrive on the district hospital. As a conclusion, this is a pilot study of intervention involving inter-hospital transfer from district hospital in lower middle income countries, and there is a significant improvement in vitals documentation and the timely transfer of emergency patient. And a sizable but not statistical significant decrease in emergency department mortality has been associated with our study, and future research is still needed for further assess the impact of interhospital emergency department intervention. Thank you very much. Thank you for your kind attention.
Hello, my name is Kathy Lee. I am a T32 research fellow at Mount Sinai Hospital in New York, and I also work at the University of Michigan. I will be discussing changes in primary care telehealth use and its impact on emergency department visits during COVID-19. I have no conflicts of interest to disclose. The COVID-19 pandemic necessitated a significant decrease in in-person care to prevent disease spread and conserve PPE. Telehealth visits also increased by many thousandfold relative to baseline to make up for this difference, but overall primary care visits were down. The landscape of telehealth uptake across primary care practices, and more importantly, the impact of these increases on health outcomes are unknown. Specifically, we examined differences in ED visits and hospitalizations for ambulatory care sensitive conditions as one way of looking at the impact on health outcomes. We performed a retrospective analysis of Blue Cross Blue Shield of Michigan claims data, examining primary care visits from January 2019 through July 2020, and we attributed patients to primary care practices and also assigned each practice a telehealth conversion rate, defined as the number of telehealth visits per month from March through July 2020 over the number of total primary care visits or kind of baseline visit volume per month averaged across January 2019 through February 2020. As I mentioned, our outcome of interest was the rate of ED visits and hospitalizations for ambulatory care sensitive conditions. We examined both acute and chronic, as well as kind of the aggregate or composite ambulatory care sensitive condition visits using a difference in difference analysis, comparing the time periods of March through September 2019 versus June through September 2020. Our data included 1.9 million beneficiaries attributed to about 4,000 primary care practices. 71% of practices used some degree of telehealth, but there was significant variation in telehealth adoption across practice types. As you can see, smaller and rural practices were less likely to use telehealth in the first place and had lower telehealth conversion rates even when they did use telehealth. This slide shows the trends for ED visits and hospitalizations in general, as well as for ambulatory, acute and chronic ambulatory care sensitive conditions. You can see that visits for these conditions dropped more precipitously than overall visits, particularly during this shaded period, which indicates March, April, and May of 2020. Given these large fluctuations in care, we excluded these months from analysis. This table shows the results for the difference in difference analysis for chronic ambulatory care sensitive conditions. We classified practices into low, medium, and high telehealth adoption tertiles, as you can see in the shaded gray box. And the red rectangle is just highlighting the actual difference in difference interaction terms that we're interested in. So compared to the reference group of the lowest telehealth tertile, practices in the highest tertile had higher odds of having a visit for a chronic ambulatory care sensitive condition during the COVID study period. However, the odds ratio of 1.6 is relatively small compared to some of the other individual patient factors, such as patient comorbidities. Medium telehealth adopters also did not have significantly different visit rates for ambulatory care sensitive conditions. And when looking at acute ambulatory care sensitive conditions, we found similar results, but with even smaller kind of odds ratios. This graph shows a stylized version of the difference in difference results for composite ambulatory care sensitive visits. As you can see, practices that are high telehealth adopters in yellow have a higher rate of visits per 1,000 patients per year at baseline compared to low telehealth adopters. But this difference actually increases slightly during the COVID study period. Our study had a number of limitations. Our data source only included patients with commercial insurance and did not have information on a number of potential confounders such as race or education level. And our study period also had large fluctuations in care due to COVID. So telehealth and in-person visit rates, as well as visits for ambulatory care sensitive conditions, may not have reached a steady state yet. In conclusion, telehealth adoption was uneven across primary care practices, with larger urban practices using more telehealth and leading to concerns for the potential for disparities in access to care among patients of smaller rural practices. We also found that practices with higher telehealth adoption had slightly higher rates of acute care visits for both acute and chronic ambulatory care sensitive conditions. but this overall difference was small, and additional research is definitely needed to determine the longer-term effects of widespread telehealth adoption as care patterns stabilize. Thank you very much. This is my contact information, and I am available for questions.
Hello, thank you for joining me. My name is Clint Hobson, and I am to present the ED utilization within a rural health network during the COVID-19 pandemic. In 2009, we saw the H1N1 pandemic led to an 18% increase in ED volume. During the early phase of the COVID-19 pandemic, significant public health measures were enacted. Statewide stay-at-home orders were put in place in New York State and Pennsylvania in mid to late March 2020. Our health system is comprised of 4 hospitals across 7 counties in northern Pennsylvania and the southern tier of New York State. They are predominantly rural communities with an average household income below the US average. Our study hypothesis was that there was a significant decrease in ED utilization and hospital admissions for critical illness, stroke, and acute coronary syndrome during the early phase of the COVID-19 pandemic. Furthermore, we believe that severity of illness for patients presenting during this time was significantly increased. To study this, we developed an observational retrospective cohort analysis evaluating the impact of early public health measures or stay-at-home orders on ED utilization in a rural health system during the early phase of the COVID-19 pandemic. We compared January 1st, 2019 to May 31st, 2019 to January 1st, 2020 to May 31st, 2020. Our study group was the beginning of statewide stay-at-home orders in New York State on March 19, 2020 through May 31st, 2020. Our primary outcome was overall ED volume using a regression model for analysis. Our secondary outcomes included rate of ED presentation for critical illness, sepsis, stroke, and acute coronary syndrome, utilizing mixed effects logistic or linear models. Severity of illness was defined as 30-day inpatient mortality. Sepsis severity of illness was defined looking at QSOFA and vasoactive medication utilization. Stroke severity of illness looked at modified Rankin scores, thrombolytic use, and thrombectomy. Acute coronary syndrome looked at cardiac catheterization utilization and vasoactive or inotropic support utilization. Overall critical illness for our study was defined as ICU admission, vasoactive or inotropic support, ventilatory support, STEMI, stroke, and sepsis. Our results, we found a overall decrease in health system ED visits during the study group when compared to all 3 reference groups. There was an increase in patient age, no change in disposition, and overall ED metrics had improved where we found a decrease in ED length of stay, decrease in door to provider time, and decrease in door to disposition time. Our primary results here, looking at secondary analyses, we found that there was an overall increase in inpatient mortality in the study group compared to the reference group, that there was an increase in critical illness rates in the study group compared to the reference group, and that there was an increase in vasopressor utilization overall in the study group when compared to the reference group. We found no change in acute coronary syndrome presentations or procedures used during ACS. We did find an increase in stroke rates, however, no increase in TPA utilization. We found that there was increase in sepsis presentations, but no increase in vasopressor utilization with sepsis. Our primary outcome here is depicted looking at a time series graph comparing 2019 ED visits on a weekly basis compared to 2020 ED visits. Here we see a significant decrease in ED presentation or ED visits in 2020 when compared to 2019 after mid-March. Rates of critical illness were significantly increased as well in the study period when compared to all 3 reference groups. In conclusion, we found a decrease in ED utilization during the early phase of the COVID-19 pandemic. There were higher rates of sepsis, stroke, and overall critical illness. Patients presented later in their disease course with higher QSOFA scores, higher vasopressor use, higher inpatient mortality. However, there was no change in cardiac catheterization, thrombolytic use, thrombectomy, are the modified Rankin scores. We feel that we should continue safe staffing models during public health crises in the future. Most importantly, we must consider the significant time, about 7 minutes in one study, for donning and doffing for each patient encounter. We believe that efforts at the local level should be made so that local or regional health leaders can provide reassurance and transparency, such as sanitation practices, testing capabilities, personal protective equipment availability, and disease prevalence to the community that they serve during all future public health crises. Thank you so much for your time today.
Hello, my name is E.T. Tang, and I'm a PhD student in statistics at NC State University, as well as a researcher in the Emergency Medicine Department at the Icahn School of Medicine at Mount Sinai. Today, I will be speaking about our project, Regional Factors of Variability in Population-Based Outcomes in Sepsis. We have no financial or intellectual conflicts of interest. In terms of grants, we have grant support for data purchases from an R01 from NHLBI, and a collaborator of the project had federal funding from multiple agencies. We all know that sepsis is very important. At least 1.7 million adults in the US develop sepsis every single year, and nearly 270,000 die. 1 in 3 patients who die in a hospital is a result of sepsis. A regional view to this problem is also very important. Existing research has shown that sepsis survival varies significantly across the US. Our team has done other important work in geographic attribution for emergency care. Geographic attribution takes populations into account instead of only the patients at a single hospital, and looks to improve outcomes for entire communities. There's been little research on sepsis network of care apart from the work of Moore and Wang. There are coordinated systems of care for other critical care diseases, such as trauma, but not for sepsis. The role of hospital performance and community factors in sepsis regional outcomes is still unclear, and that's why there's a need for further research in regional approaches to sepsis care. Our objective is to measure inter and intra-cluster performance using clusters derived from sepsis Medicare claims. We hypothesized that high-performing clusters and low-performing clusters would have different characteristics in terms of the distribution of hospitals within the cluster and demographic features. In terms of methods, first we did clustering. We derived regional clusters from age-eligible fee-for-service 2013-2014 ED-based Medicare claims for sepsis. Then, residential zip codes were attributed to clusters using agglomerative hierarchical clustering with at least 1 hospital required for cluster formation. To the left here is a map of the regional clusters that we derived. Next, we used a generalized linear mixed effects model that included fixed effects for age, gender, race, and comorbidities, and a random effect for hospital. ODE values were calculated by summing the number of actual deaths and dividing by the summed predicted probability of death. Hospital factors were estimated using the AHA annual survey and CMS cost reports, and community characteristics were estimated using the US Census Bureau American Community Survey. We found our high and low performing clusters. From now on, we'll denote by HPCs and LPCs by the top 20th and bottom 20th percentile of ODE ratios. Then we compared the hospital factors and community characteristics using t-tests. We looked at hospital factors such as number of visits, number of beds, and community characteristics for the county where the hospitals reside, including percent non-white residents, median household income, percent unemployed, percent uninsured, etc. Here are some of our results. This is a map showing the best and worst sepsis cluster regions that we found in the US. The green regions show the best clusters, while the red regions are the worst sepsis clusters. We found that average ED visits ranged from 1,000 to 207,000 for HPCs and 3,000 to 71,000 for LPCs. Average total admissions ranged from 700 to 57,000 in HPCs and 1,000 to 17,000 for LPCs. This shows us that HPCs generally included larger hospitals, and they have more average ED visits, more average total admissions, and more of the HPCs have much higher average total admissions and average ED visits than the LPCs. We also found that HPCs had 2.3 times as many average number of hospitals per cluster with an ODE value less than 1 compared to LPCs. HPCs had more total staffed acute, surgical, and ICU beds on average per hospital. They had more uninsured and unemployed residents within the county, and the HPCs were more diverse in terms of county residents, race, and ethnicities. In conclusion, we found significant variation in hospital and demographic factors between HPCs and LPCs. This shows that outcomes for sepsis may be attributable to factors both within and outside of the healthcare system, and that complementary efforts are needed between community-based outreach and hospitals to improve population health. Thank you so much for listening, and please let me know if you have any questions. Special thanks to the other research team members.
Hello, my name is Rafael Cortez.
And I'm Ethan Chang, and we are undergraduate students at the University of Michigan. We are pleased to present our research titled A National Survey of Expedited Partner Therapy in Academic Emergency Departments.
According to a report by the CDC, from 2014 to 2018, gonorrhea cases increased by 63%. During this period, chlamydia cases increased to over 1.8 million cases, the most cases ever reported to the CDC. Additionally, the CDC estimates that 1 in 5 Americans had an STI at any given day in 2018. So why does this matter to the ED? Well, STI visits in the ED have been outpacing the general rise in all-cause ED visits. ED see a disproportionate share of STI cases compared to other settings. Emergency departments diagnosed similar proportions of all gonorrhea cases as STI clinics in 2018. Moreover, STIs are an issue of social justice and health equity. STIs disproportionately affect those with low healthcare access, racial minority, and low-income populations. The same vulnerable populations which are more likely to use the emergency department for STI care.
Part of the issue in STI control is that the standard approaches for partner notification are inadequate. In areas of highest STI-related morbidity, partner notification rates were as low as 12% and 17% for chlamydia and gonorrhea, respectively. This is where EPT comes in. Expedited partner therapy is the process of treating the sexual partners of patients diagnosed with an STI without an intervening medical exam, and is used when a partner will not seek care otherwise. EPT has shown to be effective at breaking the cycle of STI reinfection. In a meta-analysis, EPT reduced reinfection rates by 29% and increased the number of partners treated per patient when compared to telling the patient to have their partner treated. In terms of legal status, EPT is legal or potentially permissible in all states but South Carolina. Lastly, many physician organizations support the practice of EPT, including the CDC, the American College of Emergency Physicians, American Bar Associations, American Academy of Family Physicians, and American College of Obstetricians and Gynecologists. Despite the urgent public health need and the critical role EDs play as a setting of care to combat STIs, little is known about the implementation of EPT in this setting.
Our objectives include characterizing the knowledge and beliefs of emergency physicians and operation leadership positions concerning EPT. Additionally, we seek to explore barriers and facilitators to EPT implementation.
We developed a cross-sectional survey to evaluate the knowledge, interests, acceptability, and appropriateness of EPT. Between July and September of 2020, the survey was distributed to 70 medical directors that were affiliated with the Academy of Administrators in Academic Emergency Medicine. Following the electronic distribution of the survey, we were able to calculate the proportion of ED medical directors that had knowledge and expressed interest in implementing EPT. Additionally, we used descriptive and bivariate statistics for primary analysis and multivariable regressions to explore predictors of EPT implementation.
48 of 70 medical directors responded to the survey. 73% of medical directors were aware of EPT, but only 38% knew how to prescribe. When it came to having implemented EPT, only 19% had done so. Despite low implementation levels, most of the medical directors, approximately 79%, supported EPT. For EDs that had not yet implemented EPT, 41% EPT was feasible, and 56% thought departmental support would be likely. Lastly, we found that increases in ED rates of Medicaid patients were significantly associated with increased support for EPT, while years in med director role was associated with less support.
This graph illustrates the perceived barriers to EPT and how much of a concern they were to medical directors. Legal liability, affordability of the medications, and intimate partner violence were most frequently cited as the highest level of concern. Additional concerns include misdiagnosis, adverse reactions, and complications with pharmacy.
On the other hand, most med directors rated potential benefits of EPT with high levels of importance. Over 75% of medical directors said that the potential benefits of EPT were either very or extremely important. These benefits were increasing access and treatment among marginalized populations, addressing untreated STIs, and preventing STI reinfection and sequelae.
What we found was that academic emergency departments nationwide had low levels of prior knowledge or use of EPT. However, they had high levels of interest and reasonable levels of perceived feasibility of implementation. Increasing awareness of EPT and supporting ED-based implementation presents a key opportunity to improve reproductive health in marginalized populations.
Thank you so much for your attention. We'd like to acknowledge the study team and the University of Michigan Emergency Department for their support in making the study possible. At this time, we will take any questions or comments.
Hello, my name is Craig Choucher. I'm a research fellow at Hennepin County Medical Center, and it's my privilege to present to you our work on hospital closures and changes in Medicare-covered ambulance trips among rural emergency medical services agencies. I have nothing to disclose. Quick background. Modern EMS was created in the United States in 1973. This is to provide a coordinated regional framework for emergency transport. Currently, there's approximately greater than 21,000 EMS agencies in the United States, providing a little over 16 million transports per year. This role is diversified originally from pre-hospital care, now expanding into public health roles as well. There's generally three types of ownership. A little over half are municipally supported, over 13% are volunteer-based, and a little over 33% are privately operated. Guard EMS has increasingly had competition between municipally supported and privately operated agencies. The one thing that remains consistent is that in a 911 response, there is an obligation to respond. Air EMS has been deregulated as part of the airline industry and may select which calls they choose to take or not. Rural EMS at present is strained, as is EMS in general, but there's in poor attention, a difficulty in recruitment and high dissatisfaction, particularly in rural areas. This is exacerbated by worsening reimbursement and a high reliance on Medicare. However, they play an integral role in rural communities, as there's often a distance of greater than 30 minutes to the nearest hospital, and they provide a key aspect in non-emergent transport, which is also emerging as an increased funding source in capitally strapped agencies. To exacerbate this further, there's over 100 rural hospital closures in the last decade, which could be affecting both roles performed by EMS. Early evidence focuses on 3 studies using NEMSIS, which is a patient-based database, often used in EMS reported nationally. Rural hospital closures have been associated with an increased time in the ambulance, and increased coverage from the ACA has been implicated that this may be slowing ambulance response times. Evidence impacts on rural EMS agencies itself are presently missing, and the patient-level analyses don't really allow us to investigate which agencies are most affected, which is part of what drove us to pursue our work with 4 primary questions looking at, does this closure affect the number of EMS trips and the distance traveled? Do closures affect the non-emergent share of EMS trips? And is there a difference between air and ground agencies, as well as does the closure affect private versus publicly funded EMS agencies differently? Our methods looked at a little over 1,800 rural counties. This was done based on RUCA codes, classifying rural versus urban and suburban. We looked at the hospital closure status from the UNC Shepp Center and used EMS utilization data from Medicare. A flow diagram looking at the number of patients we started with at 57,000 observations approximately, reducing based on those that were not part or reporting to the data set over the full years of our study, those that either changed location during study or did not have closures in their service area over the course of our study. Obviously, agencies in a non-rural setting were also excluded, leaving us with a little over 32,500 observations. We used a differences in differences statistical approach to analyze our data. Our results here in graphical form shows that the total ground miles was higher in agencies located in a county with closure. The total ground trips was reduced for those agencies in a county with a hospital closure, and that the average miles per ground trip was also higher for agencies located by closure, and that the non-emergent share of ground trips was reduced. Here's a table showing the total miles and total trips, our statistical significance of 0.002 for total miles performed in counties with a closure. This is an estimate of our hospital closures on the annual EMS utilization, comparing ground versus air, with ground being more significantly impacted than air, although the caveat being there are far fewer data points for air agencies. And estimates for hospital closures by ownership, showing that non-private agencies had a significant increase in the average miles per trip and a decrease in the non-emergent trip share. We conclude that hospital closures are associated with a greater burden on the publicly supported EMS agencies, resulting in longer trips and more emergent trips as compared to the privately funded agencies. Hospital closures could be placing an increased strain on rural agencies, with an increased demand for longer trips, which will challenge these agencies given their decreased capital and often aging equipment, and their heavy reliance on volunteers and their decreased ability to scale up to increase EMTs and paramedics. There are some limitations, as this data is only based on Medicare information, imperfect assignment of agency ownership, no information on the care services provided, and a lack of EMS facility capabilities and labor force data. It does signify that there should be or could be value in changing policies to focus more on EMS, providing more funding, particularly where there's hospital closure. We would like to pursue this work further in the future, performing surveys looking at EMS agencies, engaging stakeholders to better elucidate the data, develop measures of EMS capacity and their financial positioning based on administrative data, and then helping to evaluate what is the role of EMS in the increasing healthcare safety net crisis. I would like to acknowledge Drs. Nikpe, Scott, and Puskarj for their incredible help in going through this work. And I pause now if there are any questions.
Hi, everyone. I'm excited to discuss our project, Emergency Department Patient Comfort, watching a standardized resuscitation code status educational video with you all today. Before continuing with my presentation, I wanted to take a minute and extend my gratitude to all of my co-authors for their hard work throughout the project. As a team, we have no disclosures. Establishment of code status for frail and critically ill patients is an essential aspect of emergency medical practice. It is often challenging to routinely perform detailed face-to-face code status discussions in the acute care setting because of time constraints. Code status discussions clarify to what extent invasive maneuvers such as endotracheal intubation, mechanical ventilation, chest compressions, and defibrillation are desired by patients and caregivers at the time of potential cardiac arrest. The primary objective of the present study was to evaluate whether patients, their surrogate decision makers, or both were comfortable watching an educational video about resuscitation code status. We conducted an interventional pilot study of adult patients presenting to a quaternary care academic emergency department with 77,000 annual patient visits from May to August of 2017. A convenient sample of 49 ED patients for whom hospital admission was ordered were enrolled. Patients or their healthcare power of attorney watched a 2-minute and 10-second educational video describing standard resuscitation procedures, including cardiopulmonary resuscitation, or CPR, defibrillation, and endotracheal intubation. Patients completed a pre- and post-intervention survey based on a 5-point Likert scale, assessing their response to the video. Data are summarized with descriptive statistics and 95% confidence intervals. 50 patients were approached to participate in the study. All 50 patients were enrolled in the study. 49 were included in analysis. One patient was excluded from the study after it was learned that the person completing the study was not their spouse or legal medical decision maker. To introduce the demographics of our study group, a total of 49 patients were included for analysis. The mean patient age in our study was 73.7 years, with a standard deviation of 8.4 years. 28 patients were female, representing 57% of the study group. 21 patients were male. The majority of our patients, 92%, were floor-bound, while about 6% went to the ICU. One patient, representing 2% of the study group, was admitted to an intermediate level of care. We did inquire into the cohort's code status before completing the exercise. 21 patients, representing 43% of the cohort, reported not knowing their code status. 31% of our group were full code, and 22% of our patients were DNR/DNI. To clarify who was completing our surveys, 45% were completed by patients, while 4 were completed by their healthcare power of attorneys. Among included patients, 41 patients were very comfortable watching the video. This represented 84% of our sample, with a 95% confidence interval of 70 to 93%. 0 patients reported that they were mild, moderately, or very uncomfortable with the video. Overall, 31 patients were very comfortable recommending the video, representing 63% of the sample size, with a 95% confidence interval of 48 to 77%. 1 patient was neutral, and 1 patient was mild or moderately uncomfortable recommending the video. We also tried to figure out if patients' perception of the video was that it was helpful to them. The majority of patients found the video helpful. 37 patients, representing 76% of our sample, found the video very or moderately helpful. 11 patients were neutral, and 1 had mild or moderately negative perceptions of the helpfulness of the video. There were numerous limitations to this study. As it was a pilot project designed to evaluate patient comfort with a new educational medium, we had a very small sample size. Furthermore, we did not look for a significant effect on code status. We believe that given our findings that patients were comfortable, this would be an area of future study. Additionally, the study did not control for past experiences with code status discussions, which may play a role in comfort watching the videos. Finally, physicians are key stakeholders in the discussion of code status. Further studies on this topic should include them and their perceptions of the content. Nearly all patients and their healthcare power of attorneys felt comfortable watching the resuscitation code status educational video and recommending the video to others. These findings indicate that a standardized patient education video on resuscitation code status was acceptable to patients and their family members and has potential for enhancing ED discussions about patient code status. Further study is needed on the topic. Briefly, I wanted to acknowledge the references that made our work possible, and I wanted to thank everyone for their attention watching our video.
Hi, my name is Mike Terciano. I'm an emergency department doctor in Brooklyn at Maimonides Medical Center. And today I'm presenting our study entitled Simulation-Based Training for Emergency Department Medicine Attendings, Changes Perceptions Around Goals of Care Conversations. As emergency doctors, we are experts at managing a resuscitation and handling a patient in crisis. However, I think we can do better when it comes to caring for our seriously ill patients who present in extremis. In the last 6 months of life, about 75% of people will present to the emergency department at least once. and most patients do not have advanced directives available at the time of their emergency department visits. This means that when seriously ill patients arrive in a crisis, it is vitally important that we emergency doctors are skilled communicators. Deliberate communication can allow us to determine what patients and their families would want in these stressful moments. However, despite the importance of these conversations, emergency physicians can be uncomfortable with goals of care discussions. To address this challenge, we sought to better understand the difficulties surrounding goals of care conversations while trying to learn about the impact goals of care conversation training would have on emergency physicians' attitudes towards communication with seriously ill patients and their families. Our study was conducted during our ongoing weekly small group faculty development program in our department. We were able to enroll 49 of our emergency department attending physicians, all of whom work at an academic urban medical center and are teaching faculty for our residency program. During the course of this project, groups of 3 to 6 learners met for 2.5 hours, and learners completed pre- and post-course surveys exploring their attitudes around goals of care conversations in the emergency department. The day started with a 45-minute didactic session discussing the challenges around end-of-life communication in the emergency department, and then learners were introduced to a novel goals of care conversation guide put together. Goals of Care Conversation Guide, which can be found in the Annals of Emergency Medicine. This particular guide was chosen as our learning resource because it was designed for use at the bedside in the emergency department by emergency physicians and provides a roadmap and a checklist for discussing goals of care in a systematic, reproducible way. After going over the conversation guide, we moved on to high fidelity simulation. We divided the learners into 2 groups, each with a facilitator and a standardized patient. Individual learners tackled cases reflecting real-world clinical challenges in front of the group. We allowed the learners and the facilitator to start and stop the case in real time to address things that were going particularly well, or more often than not, things that were challenging, to promote deliberate practice of conversation skills. After 45 minutes, the group switched and did another case. This was followed by a 10 to 20 minute group debrief. Finally, using a grounded theory approach, 2 reviewers independently coded learner responses and subsequently came to a consensus around common themes. Our study found that the main barriers to effective communication in the emergency department around end-of-life communication and goals of care conversations were a lack of space and a perceived lack of time to have effective conversations. There was tremendous uncertainty towards clinical outcomes, which made physicians hesitant to offer recommendations. And many of our colleagues reported an absence of formal training around goals of care communication and end-of-life care throughout medical school and residency. After the course, however, we found an increased comfort with goals of care conversations, more confidence in offering recommendations to patients and their families around goals of care. We found that there was an increased recognition in the utility of active listening as a tool for eliciting patient values, and a new sense that goals of care conversations can be conducted in a time-efficient manner. We also found increased motivation to have these conversations with patients and families. Putting this all together, it seems that deliberate training through simulation with a structured communication tool effectively overcame perceived barriers to having goals of care conversations in the emergency department. Through simulation-based training and using a checklist and a conversation guide, we found increased comfort and motivation to have goals of care conversations in the ED. We suspect that the described barriers are common across many emergency departments, and that focused simulation-based training can be effectively applied to bolster communication skills for emergency physicians at all levels of training. Thank you for tuning in. I want to thank the Maimonides Simulation Center, Dr. Kai Uchi, who put together the conversation guide that we use in our training. I'd like to thank Drs. Karita Grudson and Audrey Tan for sharing their cases that they're using currently on their EM Talk research project. and the folks at Vital Talk who do palliative care communication training around the country. If you have any questions, shoot me an email at mterciano@maimonitiesmed.org. Thank you for your time.